Big news! Multiple generic entries for Farxiga, dapagliflozin, are expected this April before others in the class. Another reason to prescribe Farxiga today. View efficacy and safety information at farxiga-hcp.com.
Farxiga.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, everyone, and welcome to the CardioNerds Pulmonary Embolism series. PE is the third leading cause of cardiovascular death, and its management is rapidly evolving. It's been called a silent killer. It strikes suddenly, often with devastating consequences, and for decades, treatment options were limited and fragmented. But that paradigm is shifting. The modern management of pulmonary embolism requires a village, or rather, a response team. To bring you the absolute best evidence and expertise, we've partnered with the pioneers of team-based care, the PERT Consortium, to develop this podcast series covering the latest and greatest in PE care. Over the course of this series, we'll be joined by multidisciplinary experts to take you from the basics of risk stratification to the cutting edge of advanced therapies. Whether you're in the ED, the ICU, or the cath lab, this series is designed to arm you with the tools to save lives. My name is Dinu Balanescu, incoming interventional cardiology fellow at the Mayo Clinic in Rochester, Minnesota, CardioNerds Academy house faculty leader, and co-chair of the PERT Consortium Trainee Council. And I'm joined today by my good friend and colleague, co-chair of this series, Dr. Joe Mullinax. Billy Joe is an interventional cardiology fellow at Emory University in Atlanta, Georgia, and member of the PERT Consortium Trainee Council. Hey, Billy Joe.
Thank you, Dinu. Man, it's good talking to you. And to our listeners, we are truly thrilled to have you join us for the inaugural episode of the CardioNerds PE series, tackling the modern approach to acute PE care. This series is going to be a lot of fun. We have put a lot of effort into it, and we're really excited to finally be bringing it to you. The PERT Consortium was founded on a simple but powerful idea that a multidisciplinary team bringing together cardiology, emergency medicine, pulmonary critical care, surgery, radiology, even pharmacy delivers the best outcomes for patients in crisis. In this series, we are adopting that exact model. We are breaking down silos and bringing you globally recognized experts to discuss everything from code PE activations to long-term post-PE care. Leading today's inaugural episode is our friend Ibrahim Zahid. Ibrahim is a first-year pulmonary critical care medicine fellow at the University of Miami, Jackson Health System, and our colleague and the PERT Trainee Council member. Hello, Ibrahim.
Thank you, Billy Joe and Dinu, my co-trainees from the PERT Trainee Council. It's my absolute pleasure to join you today and to lead the CardioNerds PE series inaugural episode. To launch a series of this magnitude, we knew we had to start at the very beginning. We are incredibly honored to be joined by none other than Dr. Kenneth Rosenfield. Dr. Rosenfield is the section head of vascular medicine and intervention at Massachusetts General Hospital, but to the world of venous thromboembolism, he's best known as the visionary architect behind the very concept we are discussing today. He's the founding member of the PERT Consortium, the man who saw the need to organize system structures and unite specialists to save lives. He didn't just change the guidelines, he changed the entire culture of how we treat pulmonary embolism, and we get to pick his brain today. Dr. Rosenfield, welcome to CardioNerds.
Thank you, gentlemen. It's a pleasure to be here, and what an honor to be featured in CardioNerds this evening. I would just say that while your words are so generous, all three of you, this was a team effort, just like PERT is all about teams. Creating the PERT Consortium and getting to where we are now has been a team effort. So we'll talk a little bit about that this evening. But thank you. It's an honor and a pleasure.
Oh, goodness, Dr. Rosenfield, the pleasure is all ours. Now, before we dive into PE care, could you start by telling our listeners a little bit about your clinical background and how your work ultimately led you to focus on pulmonary embolism and the development of the PERT model?
Well, thanks for that question. I've been in practice for probably, I don't know exactly how many years, but over 35. And right from the outset, I was introduced to the concept of team-based care. Myself and my colleague / mentor, Dr. Jeffrey Isner, created a vascular multidisciplinary team-based approach at our community-based hospital, St. Elizabeth's in Boston. And it was really one of the first multidisciplinary team-based approaches in the vascular arena. I remember we used to meet weekly and review all the angiograms for the peripheral cases that came in that week. And we did it with our surgeons and our radiologists and vascular medicine specialists, which were brand new at that time. And it was really exciting. I mean, just to have the input of all of these different disciplines and all of their different perspectives really clearly, in my mind, enhanced the patient's care. And so everything I've done ever since that time has really been centered around the multidisciplinary approach. And that includes vascular medicine, vascular disease management. We set up a multidisciplinary vascular program here at Mass General when I came here in 2002, and ultimately pulmonary embolism. So I think it's been a journey and a fun one, and one that has been much more rewarding than just doing things in silos. Ibrahim, you mentioned the concept of silos, or maybe it was Billy Joe, but we are breaking down silos, and it's really important for the patient's benefit, but also for the self-satisfaction of the physicians involved in the team to break down those barriers. I can tell you a little bit more about how the PERT concept started, but I think we're going to get into that a little bit later. So I'll wait on that.
Great to hear the beginning of the journey. Let's start with the big picture. PE is often described as a silent killer. Patients can look deceptively stable yet decompensate quickly. We see PE everywhere nowadays, in the ED, in the ICU, on the floors, and post-op. Dr. Rosenfield, how has the clinical approach to PE changed over the past decade?
Well, Ibrahim, it's a great comment that people can look deceptively stable and yet they decompensate. It's really challenging, probably one of the most challenging clinical conditions that we all face. We do see PE everywhere, but it was always there. It just wasn't recognized as much. And one of the things that the PERT concept has done is shine a light on PE and make sure that everybody in the healthcare environment is aware of PE. And well, you said it's a silent killer. I kind of call it the great masquerader, because it can look like so many other things. It can look like an MI. It can look like heart failure. It can look like the flu. It can look like depression or anxiety. Any number of things it can look like. It can look like an asthma attack or a syncopal episode that could mimic something neurologic. The point is that if you don't know that these are all within the realm of possibility of presentations of PE, and if it's not on your differential diagnosis, you're going to miss it. And I think that prior to the PERT shining a light on it, I think it was missed a lot. And I think it's still missed a lot in many venues, even in busy places that have PERT teams, it still can be missed. But I think we're gradually chipping away at that and hopefully educating people, increasing awareness so that it is recognized. So I think that is definitely changing the way that we manage PE. Well, starting with recognizing it where it wasn't recognized before. And then once it's recognized, what do you do with it? And that's changed as well. I mean, clearly the PERT concept has brought it to the fore. I always like to say that we're about 25 years behind myocardial infarction and stroke in terms of data acquisition and evidence base. And that's really surprising because, as you all know, pulmonary embolism kills almost as many patients as stroke. And I actually think it may cause more than stroke. We just don't recognize it as much. And, if a person drops on the street, we attribute that always to a myocardial infarction or a stroke, but we don't think about PE. And the reality is that many patients are probably dying from PE that we're not even attributing to PE. We don't have the autopsy studies to prove that, but I have a secret suspicion that that's the case. In any event, it definitely is responsible for a lot of mortality and is actually the leading cause of cardiovascular mortality for inpatients. And yet we are so far behind on development of a good evidence base to support what we do. And therefore, we're starting to chip away at that now with PERT and with the database that PERT's developed and with our increasing awareness and our better risk stratification and better treatment modalities, frankly. And the question is, why are we so far behind myocardial infarction and stroke? Part of it is because of this issue of PE being a great masquerader, and it's really challenging to diagnose it, and it happens in the hospital, it happens in the ED, it happens, out in the field, and people are just not recognizing it. It can happen post-op. So part of it is just the different places that it occurs and the challenge of diagnosing it. But part of it has to do with the fact that there are so many different disciplines that are actually managing patients with pulmonary embolism. It might be a critical care pulmonologist. It might be a primary care doctor. It might be a hospitalist. It might be an ED doc. It might be a cardiologist, an orthopedic PA who's taking care of their patients post-op. It could be just about anybody that's taking care of pulmonary embolism. There's no specialty that really owns PE. And that is why it's different than stroke, which is obviously so-called owned by the neurology services, whether it be neurology and neurosurgery. And it's different than MI, which is kind of owned by cardiovascular specialists. So PE is an entity without a home. And that is one of the reasons why PERT is so important, and the consortium that has coordinated PERTs. It brings people together who are all interested in PE and gets us all rowing the oars in the same direction and communicating with each other.
Wow. As I was listening to you, sir, I got to tell you, it was kind of a humbling thought that the longer I've been in training, the things that I thought were etched in stone were things we're still really learning so much about. I know we're all passionate about this entity, but I don't know about my fellows in training, but it's really a humbling thought that there's so much more to do. And I hope it kind of fires us all up to continue working over the next 25, 30 years of our careers. I'd like to jump in a little bit to what you've mentioned already, and we're going to bring in a clinical vignette to kind of bring some of these details out. So imagine a 58-year-old lady who presents with acute dyspnea and tachycardia. A CT angiography found a large bilateral PE with RV dilation and serology markers that were abnormal. Anticoagulation was started. Now, 10 years ago, many of us have just continued to observe this patient closely without any additional management. Today, in the setting of evolving data, albeit behind the times, as you just said, and surrounding many advanced therapies, the discussion feels a lot more nuanced, and that could be very different depending on the hospital you're in. So what major gaps should we be aware of in traditional PE care and pathways that clinicians should be aware of at various types of hospital systems?
So, Billy Joe, great question. On the positive side, we're really making great strides in an accelerated fashion. As you can see, PEs really come into the limelight over the past 10 years. So you're right. 10 years ago, it was a different story. And at our place, when we started PERT some 13 years ago or 14 years ago, that was basically what was available. It was anticoagulate. That was the go-to. We had some patients that would get a systemic thrombolysis, depending upon how ill they were. That was the days when the Pytho trial was being run, one of the earlier randomized trials and only randomized trials. And look where we are now. We're in a whole different era. First thing is that risk stratification is much better, and we're going to talk about that, I think, a little bit. But there's now many tools that are used for risk stratification. This is one of the problems, is which tool do you use and what's the best way to stratify risk and what do the data show? And I already said that we don't have the data exactly, but that said, there's accruing data about different ways to risk stratify. The options for management have expanded greatly. So that was one of the major gaps. We didn't really have many options other than anticoagulation and thrombolytic therapy, systemic thrombolytic therapy, and even catheter-directed thrombolytic therapy was really in its infancy and wasn't used that much. So all of these things are really rapidly evolving. The development of both medium bore and then large bore thrombectomy has really turned things around. And I think we're just in a different phase right now at many hospitals, although I want to point out that I somehow feel that there's this silent majority out there of hospitals and practitioners who are really not involved with PERTs and don't really still understand about pulmonary embolism and are still not aware of it. And we have some work to do in that regard. So glad that CardioNerds is doing this because it's going to help augment the awareness of PE. So I think there are other gaps that we need to address as we develop these new treatment modalities we need to be thinking about. And one is that we understand that PE in a small number of patients will lead to this problem of CTEPH or chronic thromboembolic pulmonary hypertension. But that's only 3 to 5% or somewhere thereabouts. But we know that some patients, and maybe even a majority of patients, have some abnormalities later on. They're not ever the same, or in many cases, they're never quite the same. They're still a little short of breath. And you got to imagine if you have a big clot in your pulmonary artery, then as it's absorbed, it doesn't just all go away. There's got to be some inflammation of the wall of the vessel and so on that happens. But we don't have good data about this. So that's one of the big gaps, is what are the longer term effects of PE? How do we look at them and how do we prevent them? Will removal of clot in a more aggressive fashion prevent longer term problems? We don't know the answer to that question. And part of the reason for that is we need to develop better follow-up care. If you look at the vast majority of patients with PE, after they're discharged, they're not followed up in a regular way. It's one of the things that we're trying to work on in the PERT Consortium, is to encourage more consistent and regular and standardized follow-up for patients with pulmonary embolism. You would never send a patient with a STEMI home and then not follow them up. They'd all be followed up by a cardiologist or by somebody who has some idea about how to manage acute myocardial infarction and post-MI care. But that's not the case with PE, unfortunately. So we have some bit of a ways to go here.
You mentioned risk stratification, and I wish to shift our focus towards that. Risk stratification now drives almost every management decision. We are looking at hemodynamics, biomarkers, imaging, and clinical scores, usually all at once. Dr. Rosenfield, can you explain the role of risk stratification tools such as PESI, SPESI, scores, cardiac biomarkers, and imaging findings, and how they guide treatment decisions in real-world practice? And for our cardio nerds, we will have a whole episode dedicated to risk stratification coming up soon as part of this series.
Yeah, I look forward to listening to that episode of CardioNerds because I think I'll learn something too. I mean, risk stratification is all over the map. Different places use different scores. We have PESI and SPESI. We have the SHOX index, the BOVA score, the Hestia score, which is really about who's safe for outpatient treatment, the Geneva score, the FAST score. There's the ESC guidelines, which have their own sort of integrated score, which is based on RV dysfunction, RV dilatation, cardiac biomarkers, as you mentioned, and T-scan, so on. There's also the question of whether people are acidotic or not, which has been not really paid attention to enough, and I think is now coming into light more. And then there's the NEWS score, the National Early Warning Score, which is used by the High Pythos study, which I'm one of the co-PIs with Stavros Konstantinidis. And that's a score that's used during the patient's hospital stay to look at the evolution of a patient's symptoms during their hospital stay, not just the initial risk stratification, but what happens over time. Are they getting worse? Are they getting better? And how do we use that information to decide how best to manage a patient? So this is an exciting area. It's a rapidly evolving area. And I think that you'll learn a lot from the expert that you have talking about risk stratification. For our PERT, we'll talk about this a bit, but in our institution, when the initial evaluation is done by the PERT fellow or the PERT clinician, we always look at the clot itself on the CT, PE. We look at the RV-LV ratio, always by CT, and sometimes we have the echo available. We look at the troponin, the BNP, and whether the patient's acidotic or not, and obviously blood pressure, heart rate, and so on. I think heart rate is actually a really important marker that may be underutilized. Of course, you need to know what the patient's typical heart rate is to be able to look at what your current heart rate is. Some patients are in the 100 range, but their resting heart rate is usually 50. So we know those patients are on the borderline. And then there are others who come in with heart rates of 150 and hypotensive. So all of these things factor in, and we have an active discussion amongst all of the experts from different disciplines about what's the best treatment based on all of these factors. But in our place, we kind of mix in all of the different scores and come up with our own judgment about what's the best thing to do with a patient.
Well, in our risk stratification episode, the experts may or may not indeed be Dr. Constantinidis, so stay tuned for that soon. Now, Dr. Rosenfield, you described many challenges: variation in care, uncertainty around escalation, a need for rapid decision. So none of this is straightforward, and it does set the stage for a multidisciplinary model. So with recognizing this issue, how did you end up creating the Pulmonary Embolism Response Team in the first place? And since its creation, what evidence or outcome data became available to support the PERT model?
Well, that's a great question, and I love that question because your question actually answered itself. When we started the PERT concept here at MGH, as often is the case, it's an individual patient that kind of drives the way that we behave and the actions that we take. And in this case, there was an index case, and it was a young woman in her 30s who was pregnant and collapsed at home in her kitchen, was brought urgently to a community-based hospital where her 5-month gestational age baby was delivered urgently by C-section, and she was sent to another tertiary hospital where she had an urgent thrombectomy, which, by the way, I should mention that was the other alternative available for us back 10, 12, 15 years ago, and even before that. And it's not a bad alternative, by the way. In any event, she ultimately was not able to be weaned off pump because her right ventricle was failing. And she was sent to Mass General, accepted by one of our cardiac surgeons. And he and I worked together very closely to get her through the episode. And ultimately, she was on ECMO for a few days, went to the OR a couple of times, and had some bleeding issues and hypertension and so on and so forth. But ultimately, she completely recovered, and her 5-month-old baby got better, and everything has turned out great. But it was such an incredible experience working with the surgeon. And by the way, this was before heart teams were really a big thing. Heart teams really have only come into existence really after the PERT concept. In any event, working together with the surgeon and the critical care pulmonary team, we got this patient better, and it was extremely rewarding. And in the wake of taking care of this patient, 3 or 4 of us got together and said, we really don't know what's happening with pulmonary embolism. I had not seen much PE at MGH, and I wondered, where is it? I know it's out there. And the reality is it was out there, but we just weren't aware of it. It was being taken care of in all these little pockets, and they mostly were being treated by anticoagulation alone, with an occasional pulmonary thrombectomy, an occasional systemic thrombolysis, and that was about it. 4 of us or 5 of us decided we should pull together critical people from different specialties and talk about how we might manage PE better. We sat around a table. I'll never forget it. There was an ED doc, a critical care pulmonologist, a vascular medicine doc, and it happened to be Michael Jaff, who had written the guidelines for the AHA the previous year in 2012. It was a surgeon, a couple surgeons actually, and a couple of cardiologists. Sitting around that table, we decided that there must be a better way to manage PE than what's happening out there. Let's find out where the PEs are. And we created at that meeting the concept of the Pulmonary Embolism Response Team, a group of docs from multiple specialties which could respond quickly to a patient who was in extremis in the emergency department or anywhere else. And at that time, there was no Zoom. We had something called GoToMeeting. We had used GoToMeeting for some other multidisciplinary efforts, and we just redirected it for this. And the name PERT was established at that point by Rich Chanik, actually came up with it, critical care pulmonary guy. He said, let's call it the Pulmonary Embolism Response Team, because that's what it is. So thereby PERT was born. What happened after that was pretty cool. I took the bull by the horns and said, we'll have an executive committee of PERT. We'll meet once a week, and let's put up posters all over that tell every doc and every nurse and everybody in the hospital that if they have a patient with an acute PE that's relatively ill, that they should call this number, 1-800-4PERT, basically. It's a PERT alert or whatever you want to call it. And what was amazing was I was on call that first weekend after those posters went up, and I had about 10 calls. It was like, wow, what is going on here? There's much more PE than I ever imagined. After that, the rest is history. We decided we would establish some protocols. We would create a database. So I started the database and then passed it off to Chris Cabral, who took it to the next level. We started collecting our data. Then one of my fellows wrote a quick letter to the editor in Chest, and that was published. And suddenly we got like 30 phone calls from friends around the country saying, what are you guys doing with PE? That's very cool. We should do the same thing. I recognized that if we could put the data together, not just our own data, but if we could get data from 30 different sites treating pulmonary embolism, we would be able to answer these questions that are outstanding, that evidence gap that we've talked about before, in a much more rapid fashion. Just like the NCDR, you can accumulate data from hundreds of sites and you can answer questions very quickly. Well, the same is true for PE. Rather than having a single site report their results and try to answer questions, if you put all these sites together, then you'll be able to address the questions and the issues. So I presented the concept of putting together a consortium. We created a meeting where we invited all the people who had asked us about this to get together on their own dime, and that we would have the second day would be a scientific meeting all about pulmonary embolism that focused only on PE. So we got some industry funding, didn't cost very much. What was remarkable was the first day where we thought we would have 25 or 30 people show up, there were 90 people in the room, and we just blew it out. It was amazing. That was the day that we created the PERT Consortium, a group of aligned individuals from probably 30 or 40 different institutions, multiple different specialties. And again, the rest is history. Every year since then, we've had a meeting, a scientific meeting that was focused on pulmonary embolism. By the way, that meeting the next day featured as the first speaker that patient of mine who had delivered her baby and had a big PE. She and her, at that time, I think 2-year-old child came to the meeting, and she was the first speaker, which was very impactful. So we created committees and we created action items, and it's been really a fun ride since then. It has just gone crazy. And we, of course, created a PERT Consortium database. We're well on the way to many other initiatives, and I can talk about them in a bit, but that's how PERT was started.
Wonderful. Man, I would like to dig into one concept a little more, and truthfully, I'm going to put the heat on you just a little bit. Even within the consortium itself, there are some varying opinions. Obviously, everyone has big opinions, but on what a PERT response may look like. And you went through a lot of examples now of why this adds value, but I think one concern some people have is specifically with the number of cooks in the kitchen during the initial call. And I know many institutions may rotate who takes a call but follows the same clinical pathways. How would you say we reconcile the workflow and how it makes it worth it for the additional work for those specifically on the front lines?
Yeah, Bill, you've really hit on something there. We like to say that when you've seen one PERT, you've seen one PERT, which is to say that every PERT is a little different. Some of them are very different, and that's okay, because what this is all about is focusing on PE and trying to work out in a multidisciplinary way what's the best way to treat a patient. Now, that may mean an ED doc and a critical care doc, or an ED doc and a cardiologist, or it may be 3 or 4 disciplines involved. It may be a vascular surgeon, maybe a cardiac surgeon. It almost doesn't matter at this point. There's no prescribed way to do this. The most important thing is that there should be decision-making that's made by more than just one person seeing a patient and say, oh, I'm going to treat this patient that way, because nobody knows what the best treatment is for a given patient with PE, with a certain amount of clot and a certain amount of hemodynamic compromise and so on. Nobody can answer that question right now. So we believe in the PERT Consortium that in order to have a PERT, you got to have at least 2 disciplines involved. Beyond that, anything's fair game. And that's fine. Eventually, as we accumulate more data, we will be able to be more prescriptive about what treatment is appropriate for a given individual with a certain set of circumstances. Does that make sense, Billy Joe?
It certainly does. And I think that goes into probably how most PERTs are ran then, right? You have one specialty calling another, there's a discussion, there's a triage of what data there is. So I think that this makes sense. And then maybe for those more specialized patients, you may add on additional specialties. The person who's going to maybe be moving towards ECMO, or for instance, a pregnant patient or post-operative patient, you really need more opinions, or someone who's got a very complex hematological background. So that actually makes a lot more sense, that the PERT may look different depending on the call, and you may need more opinions because, like you just said, one PERT is one PERT.
Yeah, I think the important thing here is having a PERT brings resources to the table that may not have been available before. There may be one person that was just treating these things, and now you got more people on board. And as we work in the PERT Consortium, which I really haven't talked about much, but as we work in the PERT Consortium towards some of the other initiatives like the Centers of Excellence program, then it gets a little more prescriptive about process and resources and the fact that you need to have your administration on board, and there need to be some well-defined processes in your institution to ensure that you are actually delivering the very best care that you possibly can. The PERT Consortium itself was interesting. I mentioned the fact that we created the consortium at that first meeting. Within a very short order, I actually personally went and created a 501c3 organization to make the PERT Consortium able to do its own thing and involve people from all different institutions and not make it a mass general thing per se. It's really all about whoever wants to be at the table. It's a coalition of the willing, so to speak. And that was a really important maneuver to do, to make it a 501c3, because it enabled the consortium to also receive funds from industry independently and to have its own meeting, which has just exploded. We have anywhere between 800 and 1,000 people at each of our annual meetings, and it keeps growing in its size and its influence and its complexity and the information that's shared at these meetings. So it's really, really been fun. But that was an important component to make this a not-for-profit that was owned by everybody who was involved.
Awesome that how we were talking about how PERT Consortium came into existence. Since its inception more than 10 years ago, the consortium has become more than just a network today. It's now a hub for education, research, and quality improvement. What are the main goals of the PERT Consortium today, Dr. Rosenfield? And how does it support clinicians and institutions involved in PE care? I'm sure you're very excited to talk about that.
Yes, I am really excited to talk about that, Ibrahim. The consortium has the same goals as it had originally, which is to improve care and improve outcomes for patients with PE. Of course, part of that is increasing awareness, which we've talked about, developing better treatment modalities, improving pathways, standardizing care, establishing centers of excellence that can be hub and spoke or can be independent to optimize care for patients and to really drill down on PE, and also to collect data so that we can learn from our experience and develop a better evidence base. Those things are all still major goals of the consortium. And yes, it has become more than just a network. It is definitely a hub. We continue to develop our educational resources, not just with the annual meeting, but with regular webinars and podcasts like this, which is great for you. I'm so happy that you guys have developed this. It's such a great thing. CardioNerds, we like to do the same thing. Maybe we can learn something from you all. In addition, the database has exploded. It's the largest database of pulmonary embolism ever. There were 15,000 patients in the initial version 1 of the database. Now we're on version 2.0. And within the past year, when we rolled it out about a year ago, in combination with MCOR, our partners at Michigan, who we pay to sort of run the database, we have now an additional 5,000 patients in the database, and it's growing year in, year out, month in, month out. I'd encourage everybody listening to this podcast to explore the database, to try to get your institution involved. That will give you access to the ability to write proposals for mining those data. This year, we have this amazing number of proposals that our research committee is looking through and poring over and coming up with the ones that we'll fund. It is not limitless funds, so that I think we're ending up supporting about 5 or 6 proposals this year, but that's a fraction of the number that actually were submitted. So as the data accumulates and we get to 40 or 50,000 patients in this database, it's going to be incredibly helpful to expand our knowledge base. The other thing that I mentioned that I think is really important is the centers of excellence. We had over 250 hospitals express an interest in becoming a center of excellence. We now have almost 25 that have actually gone through the process. It's an incredibly rigorous process that was developed by the consortium, spearheaded by Steve Pugliese, who's at Penn, and also Mahir Elder, who's the current president of the consortium. Those two really took this thing on, and with the committee, developed the most rigorous and really wonderful criteria for a center of excellence in pulmonary embolism. I've sat in on some of these reviews, and they have really driven some institutions to develop amazing programs. I'm blown away by some of what some of these hospitals have done to establish themselves in standardizing protocols and getting lots of people involved. It's really remarkable. I think it's definitely going to elevate the care of PE around the country and around the world. And I'll add the fact that we now have a huge international component. The consortium is very well subscribed by international members. There are some 15 or so, and maybe more now, I'm not exactly sure, it keeps growing, centers around the world which have active PERTs and are now looking to be centers of excellence. So that's pretty exciting when you can think you have a world, when you think about the fact that this has a worldwide influence, and that it's going to save, at the end of the day, this is really important because it's saving thousands of lives and has the potential to really make an impact worldwide.
Sir, you really led into my next question. I actually answered a lot of it, so I'm going to be pretty specific in my question now. You mentioned a lot of benefits for both the clinician and a specific center by joining the consortium. Clinicians have access now in networking with people all over the world. And then by process of evaluating how other systems have been successful and going through the process of trying to get a designation of center of excellence. So you would say that those are obviously benefits. What other benefits might a clinician or a system get with participation with the PERT Consortium?
Oh, there are a lot of benefits. You mentioned many of them: the ability to learn from other systems, the ability to share experiences. We now have a pediatric PERT initiative as well. I think the other thing is for individual physicians, this has been a real boon to many, and you all are part of that actually, as part of the training council. That's one of the many programs we have which have allowed people to develop their own professional careers, whether it be by participating in a leadership experience like what you're doing with the trainee council. And I think you all can speak to how great that's been, but also for rank and file members to be able to participate in committees and actually have an influence on what is the output from PERT and come up with ideas that turn into initiatives that get funded. That's been a real pleasure for me to watch. I love seeing people like Mae West and Jim Horowitz and Maya Surhall, my fellow, now my colleague, and Eric Sisemsky, Jay Geary. All of these folks started early in their careers with the PERT Consortium, and the PERT Consortium really gave them all kinds of opportunities to develop their professional careers in an area which is not as well, it's not as overpopulated as some of the other areas. For example, if you want to write a paper about, a stent in STEMI or something about imaging in the coronaries, there's enormous competition for that. But in the area of PE, because it's such an orphan area that has not gotten as much attention, there's not only is there more opportunity, but there's fewer people that are trying to do this. So like I said, it's a coalition of the willing. If you're willing to put your time in and energy into this and you have that fire in your belly, you can actually make it count, which is pretty cool. So we've seen lots of people develop their careers involved with the PERT Consortium. It's a young organization made up of younger people in general. I think I'm the oldest dog in this game. And it's been fun for me to watch and be able to mentor some of these folks and watch their careers develop. Jay Geary is now the lead author on the new AHA-ACC guideline that's coming out. That's remarkable because he was a fellow under me when PERT was just beginning. And Eric Sisemsky has written more papers than I can count, a lot of them involving PE, but PE actually gave him one of his starts, I should say. And that's true for many, many other individuals. So I think there's opportunities. Frankly, I tell people at your stage and at the people who are listening on this podcast, if you want to do something in PE, there's every opportunity. Get involved with the consortium right now. It's open season. Anybody can get involved. And you can be involved in the research component. You can be a champion at your own institution, because most institutions don't have very well-developed PERT teams like they have STEMI teams or stroke teams. So there's an opportunity to get involved and to be a champion.
Amazing. I want to take a moment to speak about these young people that you mentioned. A large portion of the CardioNerds audience is made up of medical students, residents, and fellows who are very eager to make an impact but may not know where to start. For trainees interested in pulmonary embolism care in PERT, an area that sits at the intersection of hemodynamics, imaging, critical care, and procedural decision making, how do you think a trainee or a fellow in training be a champion at their institution? Does PERT provide assistance, and how can they really contribute meaningfully even before fellowship or becoming an attending?
I guess my answer is yes, yes, and yes. There's every opportunity. Get hold of the PERT Consortium through the email or through one of the other leaders in PERT that you know of. Call me or call one of you guys, because you guys are very involved in PERT. So we do rely upon people like you all who are now in leadership positions. As you're in the trainee council, you are now in leadership positions. So it's really your role to help mentor the next generation. I think, and every one of us in the PERT Consortium feels that it is our role to mentor. So I would suggest that if you're a medical student or you're a resident and you're interested in PE, that you write the consortium, and we'll try to hook you up with the correct mentors who can nurture you along. We certainly need to do a little more of that. Certainly listen to the podcasts, get involved in the local PERT team, express your interest to the leaders at your institution, and then be well read about PE, because, it does take a little effort on people's part to be knowledgeable about PE so that you can speak the language, so to speak. So that's what I would say. There are committees that have opportunities for trainees. Again, call the PERT Consortium. Michelle Lano is the CEO, and there is an admin mailbox. There's ways to get in touch with PERT. There's also a website, which we're going to revise and upgrade. We need the help of young, enthusiastic medical students and residents and fellows to do those kinds of things that are electronically oriented, like the CardioNerds podcast. We need people who are savvy with social media to help us spread the word about PE. And I would admit that that's an opportunity for those of you who are social media savvy to get involved with PERT. Offer your services. We'll use them. The consortium will use them.
Wonderful. Dr. Rosenfield, as we wrap up today, and for our listeners, again, thank you for joining us. But for our listeners today, especially the trainees, what are your top 3 takeaways about modern PE care?
Oh, that's a hard one. I have many more than top 3, but I'll just say that PE care is evolving rapidly. It's exciting. I didn't talk at all about the different modalities available, but there are now, that's number 1. Number 2, the evidence base is developing very rapidly as well. We now have randomized clinical trials that have hit the scene, and they're really impactful. So they will change care. I won't go into the various trials, but trials using large bore thrombectomy, both single-arm studies and now randomized trials using catheter-directed thrombolytic therapy and comparing to conventional therapy with anticoagulation alone. I think we're going to see much more. There's also a lot more exploration in the post-PE syndromes, which I mentioned earlier in the podcast, but need a lot more attention and a lot of work in CTEF. I do a lot of BPAs myself, which is a new thing for me over the past 5 years. So lots of new data coming out. The other comment I would make is multidisciplinary care is critically important so that people row their oars in the same direction. The team-based approach is really important. That would be my second thing aside from the data. And the third thing is to understand that PERTs save lives. They improve care. And we do have pretty good evidence developing that these multidisciplinary team-based approach through PERTs will actually improve outcomes. So those are some of the highlights. I think we have a long way to go. We need young, enthusiastic medical students, residents, fellows, and early career attendings to step up and participate, and you will be rewarded in so many ways. So thank you for the opportunity to do this podcast. I know some of my answers were long-winded, but hopefully you'll get a flavor for how this all evolved, and we'll be contributors. And 20 years from now, you'll all be on the podcast talking about how we've taken it to the next level and then level after that.
Well, Dr. Rosenfield, it was such a joy to have you today. And it's really exciting to hear that many of these aspects of PE care that you mentioned will actually have dedicated episodes on as part of our series. Now, Dr. Rosenfield, we cannot possibly let you go from a CardioNerds recording without asking you what makes your heart flutter about the modern care of acute pulmonary embolism.
I think what makes my heart flutter is the fact that we're actually able to improve outcomes and save lives. I think that the evolution of PERT has really been one of the most rewarding parts of my career. And there have been a lot of rewarding things in my career. So I've been lucky in my career, but this one is really special. The next phase of PERT and the PERT Consortium is going to be something called the PRISM program. And I would encourage you to look into the PRISM program. It's basically putting the database collection of data and inclusion of many more sites and the Center of Excellence program on steroids, putting those two programs, existing programs, on steroids, and also the PERT Partners program, which is teaching new sites how to develop a PERT and nurturing them along. And then finally, the last part of PRISM is really reaching out to the community, to the first responders or the folks that I mentioned earlier, the sort of silent majority that I think really doesn't still get PE. We're trying to now reach out and touch people who we haven't touched. I mean, right now it's a lot of people who are interested in PE and have PERTs, but there's many, many out there who don't. And we need to get to those people in order to really make the biggest impact in PE care.
This has been an incredibly insightful discussion on PE care, PERT, and the role of multidisciplinary collaboration. Dr. Rosenfield, thank you so much for joining us and for your leadership in advancing care for patients with pulmonary embolism. And a big special thanks to all of our cardio nerds for listening today to the first episode of this collaboration between the PERT Consortium and CardioNerds. As my friend Dinu just mentioned, we have many more episodes coming. So stay tuned for more insight into the world of pulmonary embolism care. This is just the start to a great series.
Thanks for tuning in to another CardioNerds episode. The audio editing for this episode was performed by me, Pacey Wetstein. I am an intern in the CardioNerds Academy, House Jones, and an MS1 at LeComm Seton Hill. I invite you to check out the episode page for show notes and references. If you found this episode informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our upcoming episodes. And now, it's time to make like an S2 and split.